Today we're going to be talking about statins and the possible adverse reaction of myalgia. And why it's so important to know about this adverse reaction is because statins are going to be given all the time, especially used in the primary and secondary prevention of coronary disease. Now, statins are also going to be the only lipid-lowering medication that has proven reduction in the patient's mortality. They work by inhibiting HMG-CoA to mevalonic acid. Now, the reason or the thought as to why muscular injury occurs are really going to be three schools of thoughts here. This one is going to be the reduction or the inhibition of the synthesis of CoQ10, decreased mitochondrial function, and finally, altered muscle protein degradation. Now, these are the three theories as to why muscular injury occurs, but again, it's not really known as to why this exactly occurs. All right, now let's go over a few definitions here. Now, myalgia means that we have muscular discomfort with or soon after exercise. So we're going to have soreness, cramping, things of that nature, and we should have a normal CK level. Myopathy means we have muscular weakness with or without increased CK levels. Myositis means muscle inflammation. Myonecrosis means we have an elevation in CK levels, and there's going to be varying degrees here. Mild is going to be when we have a 3 to 10x elevation of CK. Moderate is when we have 10 to 50 times elevation, and a severe myonecrosis is going to be when we have over 50 times the elevation of CK. Finally, we have rhabdomyolysis. This is going to be myonecrosis with myoglobinuria or acute renal failure. Now, the reason why there's so much controversy as to whether this actually exists or not is because when we look at all the studies, when we look at all the trials, there is no evidence that statins actually cause muscular injury. The problem is a lot of clinicians will report that their patients complain of muscular injury, such as soreness, tenderness, weakness, cramping, when placed on a statin. So the evidence doesn't really show this, but we have anecdotal evidence that says otherwise. So this is why there's a debate as to whether they do or do not cause muscular injury. Now, there are certain things that are going to increase the risk of having this. And really, when we look at muscular disorders, we're going to be noticing that there's going to be exacerbation of symptoms when placed on a statin. And we also notice that when we have elevated cholesterol levels, for example, when talking about diseases like ALS, we actually have a prolonged lifespan in ALS when we have elevated levels of cholesterol, which is why it's often recommended to take patients off a statin when they have these types of neuromuscular disease processes. Now, when looking at all the data, pravastatin and fluvastatin are probably going to be those that are associated with the least amount of risk of developing muscular injury. We also have to look out for other disease processes like hypothyroidism, vitamin D deficiency, obstructive pulmonary disease, chronic and acute renal failure, and medications that inhibit cytochrome P450 and or combining statins with fibrates. These are all going to increase the risk of developing muscular injury, myalgia, myopathy, and things of that nature. Now, when looking at this clinically, patients are often going to report muscular weakness or soreness in the proximal large muscle groups such as the legs. They can also report feeling a difficulty of getting up from a seated position, pain or weakness when raising the arms and or climbing stairs. Now, we have to be careful about CK levels. CK levels can really be elevated in patients with hypothyroidism and in regular muscular injury that can occur with exercise. So after running, playing sports, things of that nature, we can have increased levels of CK, and obviously we can have muscle soreness as well. When this occurs, can really happen at any time when the patient is on a statin. But for the most part, it's going to be within a few weeks of initiating therapy to a few months, and the likelihood of this being a statin-related event really decreases after 6 months of therapy. Now, if the patient is presenting with these symptoms and you feel like it might be statin-induced, then at this point, we want to take the patient off the medication and do a trial run. Now, if for whatever reason you also drew CK levels, they happen to be 10 times the upper limit of normal, but the patient is asymptomatic, this is also an indication to take the patient off a statin and then recheck the CK levels down the road and see if they revert back to normal. So if the patient is feeling this, we take them off and then we reassess. Now, if for whatever reason we notice that this is statin induced, but the patient has to be on a statin for other diseases like diabetes, or they've had a previous MI, and we really want to see if there's something we can alter in their regimen to place them right back on the statin. So things we might look at are going to be first drug-drug interactions. Are they taking another medication that is going to increase the risk of myalgia or muscular injury? If so, we might want to change that medication. If they're on a fibrate like gemfibrozil, then we might want to switch to fenofibrate because that's going to be a better medication. It's going to decrease statin levels and decrease the risk of having muscular injury. We're also going to want to correct any hypothyroidism. If the patient has hypothyroid, that in itself is also going to cause myalgia, muscular pain, muscular weakness. So we want to correct the TSH level. We want to check for vitamin D deficiency. Patients with vitamin D deficiency are going to be more at risk of developing muscular injury, so replace with vitamin D. And finally, if all of this has been done, there's still nothing, we can try changing the medication to pravastatin and fluvastatin because, like we said, these have the less likelihood of developing muscular injury. Let's say we've done all this and the patient still has muscular pain. Well, at that point, then we can try doing alternate day dosing. So instead of giving the statin every single day, we alternate days where we do one day yes, one day no, one day yes. The only problem with doing this alternate day regimen is if this actually changes the possibility of decreasing mortality. All the studies normally do once a day dosing, every single day dosing, and this is what's been proven in the studies to decrease mortality. If we do alternate regimen day dosing, we're not sure if this is going to affect the patient's mortality or not. But if the patient has to be on a statin, this is acceptable as well. All right, so that was today's lecture on statins, the adverse reaction of myalgia, and how we can go about working this up and changing the regimen to decrease the incidence of having muscular injury.